Hello everyone, I hope you all are safe and healthy. I'm Dr. Franny Nathani, Assistant Professor at Sancheti College of Physiotherapy, Pune, welcoming all the attendees and our esteemed panelists for our panel discussion, which is on a very interesting topic, that is decoding vertigo. I'm very sure this is going to be a brainstorming session for all the viewers, since we have certified vestibular rehabilitation therapists as our panelists for today. So without any further ado, I would take this opportunity to introduce our panelists. So we have with us Dr. John Solomon. Sir is Associate Professor and heading the Department of Physiotherapy at MCHP Manipal Academy of Higher Education. He is coordinator for Center for Comprehensive Stroke Rehabilitation and Research. Sir is also clinical in charge for Balance and Vestibular Rehabilitation Unit. Sir is certified in vestibular rehabilitation from American Institute of Balance in 2017. He has 4 international, 3 national projects with 55 peer-reviewed articles with the H-index 11. Welcome to the discussion, sir. Our next panelist is Dr. Ritu Chabriya. Ma'am has received her bachelor's degree in 2006 from Sancheti College of Physiotherapy and completed her master's from Massachusetts General Hospital Institute of Health Professionals, Boston. She has also completed a certificate in vestibular rehabilitation at Emory University, Atlanta in 2018. She has completed a competency course by APTA in May 2020. In pursuit of her passion to develop and contribute towards physical therapy profession, she and her team has developed a competency course, the first ever competency course, to improve telehealth skills for a vestibular clinician. A very warm welcome, ma'am. The next panelist is Dr. Priti Zarya. Ma'am graduated from Sancheti College of Physiotherapy in year 2009 and did her master's in physiotherapy, specializing in neurosciences from Apex Rehabilitation Institute of Mumbai. She has completed her basic and advanced certification in vestibular rehabilitation under Bernard Tongs and completed her extra course work in concussion rehabilitation. Ma'am has completed a certificate of competency course in vestibular rehabilitation from Texas. Welcome, ma'am. Our fourth and final panelist is Dr. Dhara Kapoor. Ma'am has 17 years of combined experience as a clinician, a teacher, and a researcher in the field of physiotherapy with a specialization in neurology. She has completed Healthcare Analytics Certificate Program offered by UC Davis, California, USA. She has conducted various workshops on research pathology, vestibular rehabilitation, and stroke rehabilitation. Hello, ma'am. It's an honor to have you here with us. On behalf of Sancheti College of Physiotherapy and PhysioTV, I thank you all once again. And I now request Dr. Dhara to take the session ahead.
Thank you. Thank you, Franny, for this kind introduction. And I would also like to thank Sancheti Hospital for giving us this opportunity in the form of PhysioTV to share our clinical experiences. Most of you will agree with me that the key to solving or resolving our patients' clinical problems lies in accurate diagnosis. In our careers, at some point of time, we all have come across experienced clinicians who always get it right. They're bang on with their diagnosis. What makes them different? There was a very neat study that was conducted by Susan Wainwright and her colleagues in 2011. They looked at the factors that influence clinical decision-making in novice versus experienced physical therapists. They found that the experienced physical therapists use forward clinical reasoning processes, as well as observations and interactions with their patients during treatment sessions to arrive at clinical decisions. And this is what made us think that the best way to get a sneak peek into the minds of our expert clinicians would be a series of case presentations. And therefore, today's session on decoding vertigo includes 4 case presentations. These actually represent patients that have been assessed and treated by our expert panel members. And we would like to basically, we would like the audience to gain from this exercise an organized, systematic way of collecting data from the patient and using this data for planning treatment. With that, I would like to, before we start the case presentations, quickly review certain terminologies and function of the vestibular system as well as its disorders. So starting with the terminologies, can I have the first slide? In our discussion today, obviously we will be coming across terms such as dizziness and vertigo. So it is very important for us to clearly understand what we mean by them. So dizziness is a very general term that is used for describing sense of disorientation. It may include sensation of lightheadedness, heavy-headedness, sometimes faintness, giddiness, unsteadiness, imbalance, falling, or floating. Vertigo is a subtype of dizziness. It is an illusion of motion, and that sense, it usually involves a sense of rotation, and this could be rotation of self or surroundings. It usually occurs because of imbalance within the vestibular system. And therefore, let's have a quick look at what are the components of the vestibular system. Next slide, please. So the vestibular system basically consists of the peripheral sensory apparatus, which is our inner ear, the function of which is to detect and relay information about head movements and orientation of the head with respect to gravity. They relay this information to the central processing system, which includes the vestibular nuclear complex and the cerebellum. The central processing system integrates the vestibular input it receives from the inner ear with other sensory inputs such as somatosensory and visual, and provides an accurate information of head position and movement in space. So the output from the central processing system then goes to the ocular muscles and the spinal cord to serve 2 reflexes. One is the vestibular ocular reflex and the vestibular spinal reflex. Both these reflexes, in conjunction with the descending motor systems, control whole body equilibrium as well as stabilization of gaze. So naturally, logically speaking, any disruption in the functioning of any of these parts of the vestibular system will lead to postural instability as well as problems with gaze. And therefore, to understand the general disorders of the vestibular system, can I have the next slide, please? They could be classified based on location. So whether there is involvement of the peripheral apparatus or the central system. In the central vestibular dysfunction, usually refers to any kind of vascular lesions, ischemic or hemorrhage to the brainstem or cerebellum. There could be involvement of the white fiber tracts because of traumatic brain injury or demyelination. And so you have, the central vestibular disorders. And in the peripheral vestibular disorders, they could be further classified based on the type of dysfunction. So you could have reduced dysfunction, distorted dysfunction, or fluctuating dysfunction. By reduced, we mean that there is reduced ability of the peripheral sensory apparatus to relay information to the central processing unit. In which tends to occur in conditions like your vestibular neuritis, age-related vestibular hyperfunction, or if there is drug-induced ototoxicity. In distorted function, what you will see is that the ability of the sensory apparatus to relay information is intact, but the information that it is relaying is inaccurate. This occurs in the conditions such as the benign positional paroxysmal vertigo, wherein there is mechanical disruption of the otocornea and they move from the ventricle into the semicircular canals. And so the information reaching the central processes is distorted. And then we have the fluctuating dysfunction, wherein there are periods of dysfunction that may occur within the vestibular system. And so we have periods of normal function followed by periods of abnormal function. And we see this kind of dysfunction in Meniere's disease and perilymphatic fistula. With this background, I would now like our first speaker, Dr. Priti Zarya, to start with her first case presentation. Thank you. Over to you, Priti.
Thank you, ma'am. Thank you, Franny, for giving such a wonderful introduction. I really appreciate it. And I would also like to start by thanking Sancheti Institute College of Physiotherapy, my alma mater, and PhysioTV to give me this opportunity to speak about my clinical experience as a vestibular therapist. So I really, really thank for that. And with that, I'm going to present 2 case studies today. So let's start with our first client, that's Danielle. So, yeah. So Danielle is a 65-year-old retired female, and she came with the complaints that 1 week ago she rolled on the bed and woke up with room spinning vertigo. She was very, very specific about the word room spinning. It was worse on the left side. She was nauseous. There was low-grade headache. She did try Epley's maneuver, but it didn't help. So she looked into YouTube. She felt that spinning sensation. So looked into YouTube and did that Epley's maneuver, but it didn't help for her. And she also reported that there's difficulty in focusing when she gets that spinning sensation. She has had the same episode 1 year ago, which went away on its own. So she was aware of what it felt like. Medical history-wise, she was pretty clear. There was just history of panic attacks and other stuff, which does not correlate very well to her spinning episode. There is history of motion sickness in childhood, and she has small eustachian tube that was taken care of when she was a child. There was history of cluster headaches due to coffee, but it was not anymore. There's no history of migraines, no light or sound sensitivity. There was mild tinnitus and popping in ears, but she said that she always had it, and this was not associated with her current vertigo. There was no history of falls, so that also rules out other stuff for us. In medication also, she's pretty much clear. She's just only taking multivitamins and hormone replacement therapy. So the assessment for Danielle was done virtually, and we started by assessing her cervical spine range of motion. Her rotation, side flexion were decreased, age-related decrease was there, but she did not have any pain or dizziness associated with those range of motion. In extension and flexion were good. I always like to assess a little bit of neurological before I go about doing the vestibular assessment. So cerebral testing, that came negative. Oculomotor exam was normal for her. Before going to BPPV testing or the vertigo exam testing, I like to do seated vertebral artery tolerance test because it puts the neck in that 45-degree position with the slouch posture, so extension. And then we obviously observe for the VBI signs, that is vertebrobasilar insufficiency signs, and that was negative in her. And this was a modified vertebral artery tolerance test that I did for her. And then I directly went to the vertigo exam because her history and symptoms correlated that I should directly assess her for BPPV. Yeah. So for her BPPV exam, because this was a virtual examination, I did wanted to see her nystagmus quite clearly. So I used loaded Dix-Hallpike, which Endera in 2020 proposed to have to do this, which gives longer duration of nystagmus, stronger symptoms, and improved sensitivity than the standard Dix-Hallpike. The only difference between standard Dix-Hallpike and loaded Dix-Hallpike is There's 30 degrees of neck flexion. Patient goes into 30 degrees of neck flexion, remain in there for 20 seconds, and then you directly bring the patient back to the Dixwall pike position, and you notice the nystagmus. Since in our history, she mentioned that left was worse, I started with the right side, which came negative, and left definitely came positive for her. So what I observed was there was upbeating, left torsion, nystagmus with latency, and it was short duration. It lasted less than 1 minute. Actually, it was only 15 seconds that it lasted. So with the symptom presentation, with the history, and with the loaded Dixwall pike testing, I came to conclusion that the diagnosis was made that this is left posterior semicircular canal, canalithysis, BPPV. And then we further went ahead and worked on her treatment. So I'm just going to quickly, so if the patient comes to the clinic, then we use either the infrared goggles. We test it that way, but you can do it without the goggles as well. So the rotational component is quite strong here. There's upbeating, and then it stops in 15 seconds. So that's very, very classical of canalithysis, posterior semicircular canal type of BPPV. So what is BPPV? As Dhara ma'am mentioned briefly about it, I'm just going to quickly run through this. It's a biomechanical problem in which one or more semicircular canal is inappropriately excited due to the dislodgement of autocoin conia, which are right here. They are the calcium carbonate crystal, and they result in vertigo, nystagmus, and occasionally nausea. Sometimes some people do get vomiting as well. So we have to ask them about these symptoms. As the name suggests, benign means it's non-life threatening. It's important to explain this to the patient because it helps them decrease their anxiety associated with dizziness too. It is paroxysmal, so sudden, comes in spells. It's positional, triggered by head movements or positions. The patient will give you classic movements that triggers it, like rolling in the bed, getting up from the bed, picking something up from the shelf, or bending down to pick up something. So these positions will trigger those vertigos. And vertigo is a subtype of dizziness, and it's a very, very specific type of dizziness wherein the patient, it's illusion of movement of the surrounding or self, and the sensation is perceived as spinning. So patient will report to you that they feel spinning sensation most often. A quick go through about the features of canalithysis and cubolethysis. As we said, there is a latency, so delayed onset more than 1 second in canalithysis, and there is no latency in cubolethysis. So cubolethysis is they are the stuck crystals in the cupula, and canalithysis are the free floating crystals. Duration is short in canalithysis. That's a very, very important feature here. It's less than 1 minute, generally lasting for, it's very short burst, 15 to 30 seconds, and then it goes away. And it's long in cupulo. Direction of nystagmus for both of them will depend upon which canal is involved. For our client, for Daniel, it was posterior semicircular canal. So that's why we got upbeating and torsion, left torsion nystagmus. Upbeating and torsional. Fatigability for BPPV, the vertigo, the nystagmus will fatigue at some point in time. So that's a very, very important thing to keep in mind. This helps in diagnosing with other condition too. So what did we do for her? Since it was BPPV, I definitely educated her, but we directly jumped into canalith repositioning maneuver. Dr. Epleys in 1992 proposed this maneuver for BPPV. So patient is sitting. Turned the head to 45 degree to the side, to the affected side, and then they lay on the bed as quick as possible, keeping the head in extension. Hold that position for 30 to 60 seconds. We have to wait for the nystagmus to pass. So after the nystagmus stops, the vertigo feeling stops, then you wait for at least 30 to 60 seconds. And then you turn the head to the opposite side. So she was left posterior semicircular canal. So we have to do it on the left side. The video here is showing for the right side. So then they roll on to the opposite side, wait again, wait for the nystagmus to wait for the vertigo to pass, plus 30 to 60 seconds, and then come back and then come to the last position of Epley. That's sitting position. After the maneuver is completed once, then we can do the retesting. And I did do retesting for her, and that retesting came negative. If in retesting you're still seeing the nystagmus, then you would want to continue the maneuver. You complete the maneuver, and then you can go for a third repetition and see if it's come negative or not. Or if the patient is saying that I don't want to do this maneuver anymore, then we stop. So maximum is 2 to 3 repetition in one sitting, and depending upon the client. So she was okay for the retest. I did it. It came negative. I did not go for the third repetition. So the treatment for my client Danielle was pretty straightforward. It was a unicorn case. I educated her that it's BPPV, and she also knew about it. It's non-life threatening. It is self-limiting. So as we know, she mentioned in her past history that she got it and then it got resolved. And we did the canal repositioning maneuver. Epley's maneuver has 95% efficacy to resolve the posterior semicircular canal BPPV for the 3 repetitions that if we do it. I did give her some home advice and self-management, told her that it can recur. And if it recurs, then I would like you to try this at home only if you feel the vertigo sensation. And then a follow-up was made in a week, and I asked her how she was doing, and she was absolutely fine. So there was no recurrence for her. Yeah, so that was my client, Danielle. And if you have any question, I am ready for it. Ma'am, we can't hear you. You have to unmute it.
Thank you. Thank you, Priti. That was very kind of you to share the clinical case with us. I do actually have a few questions. One would be, which semicircular canal is most commonly involved that you have come across?
Yeah, that's a very good question, ma'am. And so posterior semicircular canal is the most commonly involved semicircular. That's around 60 to 90%. And yeah, and the other canals are, then the second one is horizontal canal. That's around 5 to 30%. And the rarest form is anterior canal. So it's easy for us to deal with posterior semicircular canal because they are quite common. Yeah.
Right. And it kind of gives us a sense of the prevalence. And therefore, if you have a presentation, the first thing that you may think about in your differential diagnosis is the posterior canal. I also saw that on your slide, you had the duration of nystagmus for the Pupillolithiasis as more than a minute. So is there a certain time period that we would expect the nystagmus to last for?
Ma'am, for Cubolethysis, the nystagmus does last longer than 1 minute. It can go up to 2 minutes. And if you keep the patient in, so the longer you keep the position, the patient will experience those symptoms, but we generally don't keep the patient in that position for more than 2 minutes. That's my clinical experience. And yeah, so that's what I do.
But I guess as long as they are in that provocative position, they are going to continually feel the nystagmus, right?
Absolutely, yeah.
Wonderful. You also said that the maneuvers that have been done, have you had experience with any other than Epley's, or have you used Epley's always for your patients?
For posterior semicircular canal, if it's canalithysis, I would definitely like to go for Epley's maneuver. But if it is Pupillolithiasis, then I would like to go for either Simon maneuver. So I can change my treatment strategy here. If it's horizontal canal, then we will go for barbecue roll. So your maneuvers will change depending upon which canal is affected.
Wonderful to know that. With respect to the maneuvers, can they be self-administered, or do you need a clinician to be present all the time?
That's a very good question. So we do recommend patients to do it by themselves as well, but it's always good to have a clinician supervised first, at least on the first time, so that they learn it well and then they can perform it on their own. So for example, why we like to empower these clients is because they can get it at the middle of the night where they won't find any therapist. So at least they should learn the maneuver correctly. So I would definitely recommend that they should see a clinician first and then they can do it by themselves at home.
That's a wonderful point that you make, because I think knowing the exact positions in which you have to be so that you can help resolve the symptoms quickly. So
Absolutely.
Wonderful. So how do you prepare your patients for a maneuver? So when they first come to you, do you have any specific instructions that you give them?
Yes, we would, since they experience nausea and vomiting, we recommend that they avoid heavy meal at least 1 hour before the session. If they have already experienced vomiting, then we would recommend, and they are afraid that they're going to vomit again, then we do recommend ginger gravel or gravel, which is an antihistamine that they can take, although it does reduce the nystagmus intensity, but they are more afraid of vomiting than us seeing the nystagmus, so that helps. I do recommend them to wear loose clothes because they can get hot, warm, and sweaty. So if they are more comfortable, then it's better. And yeah, these are some things that I do tell them to prepare.
Oh, wonderful. And in terms of, are they supposed to continue the maneuver? Say they have already had resolution of their symptoms. Do they continue the maneuver as a home exercise program?
No, they don't. So this is not an exercise, it's a maneuver, it's a treatment. So I really like to emphasize this, and then I emphasize to my patients as well, this is a treatment that you're doing by yourself if you're doing it at home, and it is not an exercise that you repeat every couple of hours to strengthen it. It is not going to be helpful. So, and there are complications also that can result because they are repeating them at home. So no, this is not an exercise.
So to be done only when you face the problem, basically, right?
Absolutely, yeah, absolutely.
Wonderful. Do you have any recommendations for any post-maneuver restrictions? Because I have come across some literature where it does not really matter. Like there is not enough evidence to support post-maneuver restrictions. What are your thoughts on that?
So there was one study that I recently saw about sleep position, so laterality. So I do recommend my patient not to sleep on the side of Bppv. So for her, I would recommend not to sleep on left side for at least 2 days, not more than 2 days. I go beyond that. So they do recommend that there's high association between the ear affected by Bppv and the preferred sleeping position. So that's one thing. If someone likes to sleep flat on the back, then I do recommend that please sleep with one pillow. And again, just for 24 to 48 hours, not more than that. So like you said, there are mixed evidence related to that, because in Hunt in April 2012, there was a Cochrane study indicated that a very small potential benefit to patients who utilize these post-postural restriction. So there's no harm in recommending the postural restriction, but a lot of other studies would negate that. There is no use. So
but I think what I hear you is that, we need to do what we can to make our patients comfortable. And
absolutely.
So if it helps to do a few restricting, recommendations for the first few days after the maneuver, that's fine. As far as, they are comfortable and don't feel like the vertigo is bothering them anymore. You also mentioned something about complications. And so now I'm going to direct my question to Ritu. In your experience, Ritu, have you had any complications related to the maneuver? Have you come across any such complications? And if so, what were they?
Excellent question, Dhara ma'am. So one of the things I see a lot is people, I luckily work with a very intelligent group of people in a large internet-based company up in San Francisco. And so people just look up their maneuvers and do it themselves. So often having the otoconia in a different canal, or converting a single canal, posterior canal Bppv to a multiple canal is really, really common. So I think in that situation, if that happens, that certainly increases their fear level, their trust level on the epi. And I would say as a clinician, I just break down the treatment sessions and make sure I see them again the next day. So first day, I'm going to clean up the posterior canal. Next day, I'll I'll clean up the horizontal canal, or vice versa, based on the one that's most symptomatic, hopefully has the most oroconia out there that we could clear. But that's one of the complications I see. The other complication I see is extreme fear to movement after knowing that they had BPPV, because they know movement of their head will trigger symptoms. So they tend to guard and not move. And that's actually something that I strongly educate about, is movement is your best friend. Do not get scared to move. Actually, you want to teach your system to move better and get used to this stimulus. So those are the things I look for, and keeping in touch with them regularly helps. Making sure you, after a week, I usually just send a message saying, how are you feeling? And the electronic medical record system makes it really easy for them to reply how they're feeling.
Oh, wonderful. So I guess I hear you, because I think that extreme fear that you're referring to, having vertigo is a very disturbing symptom. And so it's true that once we educate them, one of the things in my experience that has really worked is also telling them that this is going to go away, that this does not, it's not something that will stay. So it's okay. Whenever you feel it, you just kind of stay in that position and then just let it pass. So yeah, so I hear that. I have another question, but this time to John, because I think the kind of environment we work in, at least a decade ago, I did not have access to Fresnel lenses or infrared goggles. And I want to know, what do you think about having to do your assessments without them? What has your experience been?
Thank you, ma'am, for the question. It's a very important one, because as clinicians, we always have a doubt whether, if at all should I do this test, because I may not see anything. But in our experience, what we see is it's not a must that we need to have a Fresnel glass or a glass video nystagmography if in cases like BPPV, because you still will be able to see the nystagmus even in a room without these lenses. Most of it, like in posterior canal BPPV and all. So there it won't be a problem. But whenever we are going beyond the BPPV, conditions that can cause spontaneous resting nystagmus and all, especially with central lesions, there it's difficult to pick it up from in a room in a normal eye thing. Because once they learn to fix on a point, you lose the nystagmus. You don't really see it. So for resting nystagmus to observe, and in certain conditions of nerve injuries and all, it is better to do using the Fresnel glasses if we have access to it, or if another department, in our case, or ENT, helps us to use the video nystagmography. So there it is possible to see. Otherwise, but I would say, because majority of the cases that we see are BPPV, they don't really need a Fresnel glasses or video nystagmography always. They can do it at a clinic, still observe the nystagmus, the direction, and make a right decision on which canal and what type of pathology it is, and to treat the patients.
Thank you. Thank you, John. That was a great discussion on our BPPV case. There's only one thing that I may like to add to this whole discussion, is that there was a clinical evidence-based clinical practice guidelines that were published in 2008. And one of the recommendations that they gave was that there is an option of using observation as initial therapy. And what they meant by that is that you could ask the patient to observe. We do not do any active therapy really, meaning no maneuvers, nothing. Just educate the patient, ask them to avoid, provocative positions, and we just let the vertigo settle by itself. Like Priti had mentioned in her slide, it is self-limiting. So it's just something for us to know, that just in case you come across an extremely anxious patient who is not willing to undergo the maneuver, we still have the option of observation as a therapeutic option. With that, I guess I would like us to move on to the next case. Priti, can you please start with the next one, please?
Yeah, thank you, ma'am. So let's move on to our next client. I'm very, very thankful for this client because he has allowed me to use his videos for this presentation. So thank you, Mr. Prabhu. So he's 61-year-old retired businessman. He came with complaints of dizziness with head movements, turning on the bed, turning while walking, rolling on the bed and getting up from the bed. So these were his complaints, current complaints. So history is interesting. His dizziness started a month ago, off and on a few times, lasting for around 30 minutes. He said it was very mild. And so he was like, I just sleep it out. But on May 26th, he started feeling off. He started feeling sick in the afternoon. And by next day, he started with violent vertigo, which was he was not able to control it. There was dizziness, imbalance. He couldn't sit, nausea, vomiting, couldn't stand, couldn't walk. And he was not able to control vomiting at home with the over-the-counter medication. So the family decided to take him to emergency. There was no history of flu, fever, or falls reported by him. So he was taken to emergency the same evening. They did the blood work, CT scan, and ECG, and everything was normal. He was started with IV antiemetic. There was symptomatic management that they did there. So vomiting stopped, but vertigo persisted. So he was checked by a neurologist and also internal medicine specialist because his medical history had, we'll see some significant findings there. So the neurologist diagnosed him with Bppv and they started with Circ. So Circ is a beta histamine, which is an antihistamine, Circ is a brand in Canada that we use. It's a beta histamine. And next day, seen by a hospital physio, they did try the Canal repositioning maneuver, but there was no change in his vertigo. So they were advised to see a community vestibular therapist. And that's when I went to the hospital and did the assessment. So his medical history is significant. He has hypertension. He's on antihypertensive medication, hypercholesterolemia, angioplasty in 2012 and 2017. So that would ring my bell of something major. But fortunately, he's in the hospital. He has done the CT scan and everything else has been ruled out for him. Past history, he's never had such trouble anytime before. So not significant. So the assessment was done in the hospital. I'll play this video one more time. Higher function, reflexes, cerebral testing, everything was not negative for him. So HIMSS exam is a clinical bedside test that carefully assesses eye movements, and it helps to differentiate between the central and peripheral pathology. And our future speaker, Ritu, will elaborate more on this. So I'm just going to quickly go through. So this is the head impulse test. And if you can appreciate the positivity of that head impulse test in him. Mostly we cannot, but yeah, it was positive for him. So Nystagmus, we're going to watch a next video for it. He was negative for test of skew deviation. So there was no, so he was negative, sorry, test. So in the oculomotor assessment, like I said, he had spontaneous right beating nystagmus with mild torsion and it was non-fatigable. So this is him sitting in the room light, not doing anything. And then you see the sustained right beating nystagmus. There was mild torsion as well, but it is not appreciated in this position. I hope you can appreciate the eye videos. Okay.
Yes, yes.
Thank you. And so the Dix-Hallpike test was also done just to assure the relatives that it was not just Bppv, because the doctors have mentioned that it is Bppv. So I was like, okay, I'll show you and rule it out. And I explained them why this is not Bppv. Balance was impaired. Client was using walker for his ADL, toilet and walking for toilet and walking inside the room. Without walker, he was drifting to left side and he was using arms to stabilize himself and holding onto furniture. And since this was very acute, he was pale and fatigued. So we did not do an extensive exam on him, but definitely we came to a conclusion that it was acute left vestibular neuritis, or we can also call it as neuronitis. So what is vestibular neuritis? So Stroop and Brand in 2009 gave a beautiful seminar, and there's a paper describing about vestibular neuritis. It has very good information about it. So it is an inflammation of the 8th cranial nerve, like how we get inflammation of our 7th cranial nerve, which we commonly call as Bell's palsy. And it's most likely causes the reactivation of the latent herpes simplex virus 1. In him also, I think it was a viral inflammation. It is definitely aggravated with if you're stressed, if you're not sleeping well, if you're fatigued, these things will aggravate your chances of having vestibular neuritis. It's third most common cause of peripheral vestibular vertigo, 7%, the prevalence rate is 7%. And the key signs and symptoms, what I described before on him, all the signs and symptoms were present in him. So this is the video of his eyes in Frenzel lenses. And we are seeing the sustained right beating, non-fatigable nystagmus for him. And if he looks to the right, it settles down a little bit, but if he looks to the left, it will exaggerate. And there is a little bit of rotation component that we can see. We can appreciate a little bit of mild rotational component for him. So what is the management of acute neuritis here? So as what the doctors did, symptomatic management for first 1 to 3 days, they prescribed him antihistamine to control his vomiting and motion sickness feeling. So he was feeling dizziness all the time. Karlberg in 2011 has shown better outcome in the recovery of neuritis if corticosteroids are given within 24 to 72 hours of the attack. So when I went to the hospital, that was his 3rd day, and he was not prescribed corticosteroids. So we spoke to the doctor and we presented this paper, we gave the reference, and it's like he should be started on corticosteroid. And they did start him on corticosteroid. It was a 10-day course, 50 milligram per day for 5 days, and then taper it off after that. So that was one good thing, the one positive thing that we were able to do for this client. And then we started vestibular physical therapy. We can start it on as early as day 4, which we did, and then you progress from there gradually. So vestibular physical therapy it helps improving the central vestibular compensation of a peripheral deficit. I educated him about the condition, what it is. I taught him some grounding exercises. They're called as surface orientation exercises. They're basically, you let the patient feel the surface and experience those sensations, and coordinate it with your breathing as well. So it's almost like a meditation, mindfulness and meditation technique that will help calm down the anxiety associated with dizziness. And that really helped him. He was very appreciative when I taught that exercise to him. He's like, that takes away my dizziness right away. I feel more relaxed and calm. It's like, that's great. And then we started with VOR, Vestibulo-Ocular Reflex ×1 exercise with him on day 3, actually, when I was in the hospital. And I told him to move his head as much as he can tolerate and not keep it restricted. Balance training, after he was discharged from the hospital, I did go and see him once again. And then I started with his balance exercises. These were the patient tips, like I gave him, that the exercises are going to make you dizzy. You are going to feel worse before it gets better. And you can make yourself feel worse, but you cannot make the problem any worse. So these tips really helped him to understand the exercises, the principles of the exercises. And definitely you don't have to overdo it for the exercises to work. So he did it at his own pace. So I saw him twice before I did this reassessment. He was still in the acute stage. He was managing at home by himself. Sorry, he has a family, so they were also helping him, but he did feel a lot better. And then after a month, he was 80% better. He was walking independently. I advised him, as soon as you feel that you can go out for walking with your family, go out and do that. Movement is the key, like Ritu mentioned. that movement is so important for our vestibular function to work. So I told him, go out for walking or just have walk outside your apartment. So he was doing that, holding the wall, he was doing it. So he was able to walk independently 45 minutes to 1 hour and by himself. There was no family members with him. Functionally, he did report some dizziness with head turns. There was 3 on 10, 180 standing, 180-degree turns. There was so walking and turning. He was still feeling rolling on bed. So he did have some motion sensitivity. And then I added some habituation exercises for him. At 1 month time, there was no spontaneous nystagmus, fixation was good, smooth pursuit was good, but SICAD, he was still feeling mild dizziness with that. And head impulse test was still positive. I did find right side also positive then. It can be because of his age-related changes, or he had bilateral neuritis. But I do feel that it was more left positive because bilateral neuritis is quite uncommon. Dynamic visual acuity test is done by, you can use, we can use the chart to do it. And he was significantly affected with this. It was 0.8. He could read only 8 lines, like he could read 8 lines above the static line. So he was not happy with this test at all. Subjective visual vertical test was done using a bucket and that came negative. Balance assessment, the balance was affected in sharpened Romberg test, 9-second eyes closed. He was more affected with eyes closed than eyes open. And then the dynamic balance was also impaired. So my next goal for him was to work on his balance. And then whatever my finding was, that's how I planned his further treatment. So Stroop and Brand in 2009, the same paper, they also mentioned that we can have complications after vestibular neuritis too, and that is PPPV. So I did educated him about this as well, and we are following him. I am following up with him weekly, so that if he gets it, then I'm there for him to get it sorted. And triple PD. So our next presenter. A future presenter, Ritu, will talk more about it, so I'm not going to go into detail. And that's it from Mr. Prabhav.
Oh,
thank you.
Thank you. I must say the videos of the nystagmus were really useful. I'm sure the audience will appreciate the details that you've talked about in the case. The one thing that I would like to ask you, Priti, is that you obviously gave us a little bit of an idea of the grounding techniques. But are these techniques to be done in certain positions? Like, is there a structure to these techniques?
So these techniques can be done in any position. So you can do it in sitting, lying down, standing, or standing supported. So they are just basically, they just help you to ground yourself, they just used to help ground yourself. So as soon as you bring your attention to your feet or to the surface that's touching to the body. So for example, if I'm sitting, my thighs are touching on the chair. So if I bring my attention to that, that will help me ground better. My feet are touching on the ground. So I'll feel the sensation and that will help me ground better than feeling the dizziness.
So you instruct your patients to feel the different surfaces that they are coming in contact with. So they're supposed to pay attention to those parts of the body that are in contact. And are they supposed to kind of maintain these positions for a while? Do they do breathing at that time? What kind of instructions do you give them?
Absolutely. So they can maintain this position for 5 to 10 seconds, or to the point of if they are constantly feeling the dizziness, and they can do it for that much time. I'm so sorry, my battery is, just need to charge it. So yeah, they can do it for as long as they want to, and they can incorporate the breathing techniques with it as well. Okay. And the idea behind it is that we are using the somatosensory cues. So we're using the somatosensory system to help calm down the nervous system here.
Okay. Hey, that's really good information to have. Another thing is that in your case, obviously, Mr. Prabhav showed 80% improvement that was seen about a month after vestibular rehab. Is that correct?
So, yes, ma'am.
Could you please elaborate on the dosage of the intervention? How many times, what was done, and how many days did you ask him to do those exercises for?
Absolutely, ma'am. I asked him to do the exercises every single day. So he did them every single day. And he was very dedicated patient. So I didn't have to, I just used to go once a week and then modify the exercises. And rest of the time he was doing it by himself. So intensity was as tolerated. And I did tell him to do at least go for 3 times a day.
Okay.
So especially the VOR exercises, they were done 3 times a day. And the duration for the VOR exercise was 30 seconds to a minute to up to 2 minutes, as much as he can tolerate then. Studies have shown, actually studies have mentioned that the dosage for these VOR exercises needs to be minimum 10 minutes to up to 20 minutes. But he was in an acute phase. So I told him that as much as you can tolerate, that will be great for him to do. And
I guess you need that. I'm sorry to interrupt, but I think that is an important point that we need to make, is that we have to do this as per the tolerance of the patient, because that is only going to increase their adherence to the exercises.
Absolutely.
We already know that these exercises are going to make them uncomfortable, but if we keep pushing them to do it for, like, say 10 and 20 minutes, and if they don't like it, you probably won't see the adherence. And I guess for our vestibular system, it has its own plasticity. And and that's what we are basically trying to use with these exercises. So if we want them to adapt, they doing it consistently and frequently will be of great benefit to us and them. Right?
Absolutely. And the other thing, sorry, I'm just going to add one more point. The other thing that I told him was, do it whenever you are, it doesn't have to be specific time of the day, but you can just incorporate in your functional activities. You're going out for a walk, just shake your head, just focus on a point and just shake your head. You have your hand, you have your thumb, and then you can shake your head. So variability is the key for these exercises too.
True, exactly. And I think, just like you said, giving them those points where, pick an hour. I like to do that with my patients. Every hour, pick an exercise, do it, and just kind of keep working on it. Even with that, they will probably manage to do it, say 7 or 8 times in a day. And it's just for a few minutes. So we know that they can adhere to the program. That said, my next question is to Ritu, actually. I wanted to understand, would you recommend any other outcome measures in this particular case that we've discussed?
Priti, thank you, Dhara ma'am. Priti, first of all, awesome case and then great videos. So thank you to your patient who has allowed you to share these videos. It's really meaningful for visual learners like me to see things. So thank you. And kudos for the patient tips. Patients lean on us for these tips. And so I loved your patient tips personally. So regarding outcome measures, Dhara ma'am, so one of the things I always make sure my patient completes dizziness handicap inventory, DHI, and ABC, activities of balance confidence care. It gives me a sneak preview of how severe their symptoms are. Before even I've seen them, I kind of know that this is a severe vertigo patient. Maybe they're scared. I'll have to make my exam easier. Whereas if it's a very mild DHI score, then I can test them a little aggressively. So it gives me how to evaluate. Same thing with ABC. It tells me how much to get into balance testing on that very first visit. If they are 98% confident about their balance and they have mild dizziness, I might just address their questions, do a full exam, and if they feel good about their balance, then I might skip it and move it to the next visit based on the time we have with our patients. So really looking at these outcome measures help me personally. The other ones, like if this patient had motion sensitivity, there is motion sensitivity quotient that can be done that objectifies a score on how severe, mild, or moderate intensity motion sensitivity they have. And then based on their score, we can actually treat the low-hanging fruit, which is basically less intense motion to be habituated first, and then go into more intense motion. There is one more that I like to do is FABQ, which is Fear Avoidance Behavioral Questionnaire. We do that even for our orthopedic patients to see how much of fear is stopping them from what they're doing. And yeah, those are the big ones that I do. And then if they have 3PD or something, then I will go a little bit more in details with other testing. But I'm a big fan of outcome measures.
No, I think so. I agree with you. I think as therapists, one of the things we must be doing is recording enough data to understand the pre-post, see what we are, see, it gives us a sense of knowing whether what we are doing is working. So I think outcome measures is an absolute essential part of our practice. The one thing that I actually heard from what Ritu said, and this is exactly why we wanted to do the case presentations, is I would like to draw the audience's attention towards the detail that she gave us about using the outcome measures. See, the first thing that comes to my mind is these outcome measures were patient reported. Is that right? Most of the ones that you mentioned. So yeah, we obviously tend to do performance-based measures like your, maybe you would like to do a timed up and do test, maybe a work balance scale. I mean, those are great. That really gives us a sense of how the system is behaving when it has been disrupted. But I think the patient outcome, or rather the patient reported outcome measures, gives us a sense of that subjective feeling of the patient. And sometimes taking that into account, like Ritu said, when I'm planning, I like to look at these scores before I do certain tests or certain, treatment intervention. So I think that's a very important point here, that as far as possible, getting a patient perception of their problem through these kind of outcome measures would really help give us a better idea of how do we want to proceed with this particular person. Is that right? I mean, I think that that's a very important part of what we are doing here with them. And we must always remember that these patients are anxious. So we really need to work, it's almost like stepping carefully as we go forward with our assessments and our treatments. Thank you so much for that, Ritu. I would now, yes, go ahead. Would you have something to say?
I love, yeah, exactly what you said. Also, like when we are establishing a program in a multi-specialty hospital, having outcome measures help to measure the success of seeing a trained vestibular therapist versus not. And I think it's just important to have scientific data. The way we know this test is a good test by looking at its sensitivity, specificity. I think it's a data point that we have seen, say, 1,000 patients and they have gotten better in X number of days by this percentage. So it just you're in healthcare data analytics, and I feel like that is such an important piece to bring up this specialty beyond what it's right now.
Absolutely. I think it's very important. Like you said, yes, we need to know who are these clinicians who are able to get the best results. So that obviously helps patients make decisions as to the choice of the therapist you would like to go to for this problem. And I think it's also very important because we as therapists must get into this habit of evaluating what we are doing. And I think that is possible only if we quantify the pre and post. So having that number, because I always want to go back and say that, oh, did I expect this amount of change? If it did, great. If it did not, how do I change what I'm doing? So it's very, very important to have these numbers that are available to us, because one, it helps me as a therapist to know that I'm on the right track. And two, it also is a great reward for the patient themselves. I mean, they love to hear it when I sit down and discuss their progress. And, it's almost like a report card, and they're very happy to know that they've made those kind of changes and that they're already feeling better. So that said, actually, I would also now like to move on to John and ask him if he would have done anything differently, or would you like to add something to the assessment and the treatment?
Thank you, ma'am. First, I'd like to congratulate Preeti for the wonderful 2 case presentation. Both the cases are very interesting and gives the idea of how to deal with these patients. One of the things in our experience that we seen, as you said, one was related to the diagnosis itself. Most often, all cases will get diagnosed as PPP, but may not be PPP. So we may have to go back to the clinician to convince them it is not. Initially, we have felt a lot of restrictions way back like decades ago, a decade or more ago. But later now, we have a good rapport with the clinicians. And one of the things that when we work with clinicians, we insist on, or they also agree to this, and they work with us in treating neuritis cases, is to taper down the dosage of the medications. It's as we talk about movement is important. We don't want the patients to be taking vestibular suppressive drugs for a long period of time. So usually in the first week, though, for the symptoms, they give it high. Usually the second week onwards, the tapering starts and the number of repetition keeps increasing. So it's almost like a X kind of thing where medicine comes down and exercises increase.
Exercises take over. Sure.
So usually that works really well, and at the end of 4 weeks, we do follow patients after on a weekly basis, and then at the end of 4 weeks, when the patient is about to, is almost independent, we do advise them to continue exercises, like how Preeti advised the patient about incorporate movements while even walking. We also advise on maybe if possible to incorporate some simple recreation activities such as playing badminton, which involves gaze fixation. They have to look up, down. At the same time, involves balance reactions. So many of the in this region, people enjoy playing badminton at home, and I think it is easy to play with the children or someone. So they kind of take it up as a activity, and in one way that also ensures that they continue with the adaptation and spinal exercises.
Right.
So that's the only thing I would like to add.
Oh, lovely. Thank you so much. I mean, I've never thought of badminton that way, but that's a great idea for use in the future.
Thank you to all our panelists for those wonderful cases and panel discussion. We will see you soon for the part 2 of this panel discussion. Till then, take care.